Welcome everybody. Welcome to this fourth Ivis course we're doing here together from the Erasmus Medical University Center in Rotterdam. My name is Joost. I'm an interventional cardiologist here in Rotterdam, and I'm doing this course together with my friend and colleague Jurgen Ligthart, who is one of our key imaging specialists here in the Erasmus. Maybe we can start with showing you the slides we've prepared for you today. So as you know, as you might have seen in one of the previous editions of our webinars, what we would like to do is to provide you with a step-by-step Ivis guided PCI guide. Using the ACIST HDI system with the Kodama catheter, we will try to show you the basic principles of Ivis, help you to start learning and recognizing the different types of plaque that you might encounter, guide you through procedural planning and stent sizing, and subsequently help you to adjudicate the post-PCR result as visualized with the help of the HD Ivis system. The idea of the course is to make it very practically oriented. So we have the option to interact with you through the online chat box of the Zoom window. So please don't hesitate to ask if you have any questions. Please don't hesitate to interrupt by asking questions within the chat box. We will try to answer as many questions as we can throughout the next hour. As a specific topic of today, we have thrombus characterization and the use of Ivis in patients presenting with ST segment elevation myocardial infarction. We prepared several cases that will help you to recognize the different types of occluded coronary arteries seen from within the artery, and help you to appreciate the different types of plaques and thrombus you might encounter, and also to tailor the next PCI strategy steps according to what you see based on the Ivis. Before we start with the cases, we have prepared a few slides just to make you a little bit familiar with the types of thrombus you might encounter. Most of you will have seen all the different types of plaque that you might encounter with Ivis, like lipidic plaque, fibrotic plaque, calcific plaque. But what we haven't focused on that much up to date is the recognition of thrombus. And we believe it's good to realize that there are four key types of coronary thrombus that you might encounter during the visualization of patients with ACS. That is, on the left side, acute thrombus, there is subacute thrombus, there is organized thrombus, and there is very specific to post-stent implantation thrombus pertusion. And I would like to give the word to Jurgen to take a few minutes to guide you through each of these different types of thrombus that you may encounter, and help you to appreciate how you might recognize them. So Jurgen, please.
Yeah, I'll do. Well, if we can go back a little bit to the former slide, with thrombus, it's metathrombus is dynamic process. The thrombus, you have the start of the thrombus is different than after a while. And that is visible also on ultrasound, because thrombus changes its characteristics and changes from very inhomogeneous material like platelet aggregation to homogeneous material, what is more in organized thrombus, where you can find granulomes. And because Ivis is a reflecting technique, that the more inhomogeneous material is, the more reflection you have, and vice versa. And also, it's good to know that thrombus is coming from the lumen, from the blood. The blood is forming the thrombus, and of course, the cause of thrombus formation can be in your plaque. And that if you keep this in mind, then also on Ivis it can be very easy to recognize the thrombus. Well, we've had acute thrombus. That's actually what you see with acute thrombus is the platelet aggregation. Then the platelet starts to aggregate and you have a strong reflection. You can compare it with the spontaneous contrast, what you can see on your in echocardiography or in non-moving bloodstream if you have a closed vessel. Well, platelet aggregation, then there is always something acute going on. And if you look at the right picture there, and we put that there, then we see platelet aggregation. Well, just one moment, it starts automatically. Then we see at the left picture, we see the platelet aggregation at 6 o'clock. You see the bright, even moving part in there, and it's only part of the lumen. And then on the right side, we see platelet aggregation attached to the Ivis catheter. Well, that's a sign that something is wrong with your heparinization or platelet aggregation medication. Either it's forgotten or maybe the patient is not reacting to that. So it's quite rare that you see platelet aggregation. More common is, and that's the older thrombus, that's the subacute thrombus. That means that it's less homogeneous than the platelet aggregation, but still inhomogeneous enough that you see more reflection from inside the thrombus. I can I can tell you a lot of theory about it, why that is, but that is the less inhomogeneous than the platelet aggregation, more homogeneous, so it's darker, but you still see detail. Organized thrombus is always against the vessel wall, and that is because of the interactive of the body to the thrombus. It tries to get rid of it, so you get granulomes, it gets more homogeneous, and then so you can have a black aspect of that. And that black aspect can be quite old, can be quite a long time there, and if you try to make inflations in there, you can also appreciate that it can be quite stiff to do that. Well, we wrote a book chapter about that, which for the people who want that, I can tell you that is more in that it's more explained in detail. But those are the three parts: acute, subacute, and organized, that we're going to recognize. And thrombus pertusion. Well, thrombus pertusion, that is always if you have an ACS with a lot of thrombus and you place a stent, then normally the thrombus, often the thrombus is going through the stent struts like toothpaste and protruding into the lumen. Well, the sign is there that there is no room for the thrombus behind the stent strut, so it actually has no use to do a lot of ballooning, etc., and to try that, and even another stent will not be helpful. So probably you want to do something with your medication afterwards for that.
Yep. Jurgen, thanks for that. Yeah. We hope that this already provided you with a little bit of background on how to recognize the different types of thrombus, but we thought it would be good to show you that based on some case examples we've encountered in our routine practice in the past year. So the first case we want to show you is a male patient, 52 years of age, with hypertension, hypercholesterolemia. And this patient already had a anterior STEMI with the PCI of the LAD in 2019. And came back in 2020 with a repeat PCI for a stent thrombosis. Well, today he is presenting again with ST segment elevation anterior, suspected of having a new and a third actually STEMI anterior, for which he then underwent a Ivis guided PCI here in our center. So we started with a right radial approach. So this is the right coronary artery, showing you actually a nicely patent right coronary with some mild luminal irregularities. But what you can clearly appreciate is the occluded stent in the proximal left anterior descending artery. And that's how we proceeded by including this patient in the Spectrum trial. So this is one of the studies we're currently performing here in the Erasmus Medical Center, a prospective observational study aiming to enroll 200 patients that will go Ivis guided stenting with the Kodama system in order to assess how the Ivis will affect our treatment strategy in these patients as one of the key endpoints. So that means that we directly started with a Ivis pullback. We do that at a pullback speed of 2.5 millimeters per second, as can be very easily done with the Kodama system, while still maintaining a frame rate of 24 frames per millimeter. So that allows you to do a pullback that is 5 times faster as compared to a routine Ivis system that would do a pullback at a speed of 0.5 millimeter. So before doing anything in terms of ballooning or thrombectomy, we started with a Ivis pullback. And the key reason is that only that will help you to appreciate the true etiology of the occlusion of the stent. And without any further ado, I think, Jurgen, let's start by demonstrating us the first Ivis pullback in this patient.
So okay, so I already opened this in the workstation, and we started in the distal LED. The distal LED itself has a normal aspect, but what we see in and I know that you do not appreciate my cursor in there, but what you see around 5 o'clock in the cross section is a black mass connected with the attached to the vessel for the vessel wall. And this mass, this irregular mass, this is part of the organized thrombus. If I'm switching it on, you see that we start to pull back, and you see the blood speckling in the middle. That is the lumen. And because of that more proximal in the stent, and we're going to see that the thrombus is occluding the vessel, then we see that also there is slow flow there. So we have a brighter blood speckling in the lumen, like what we can appreciate in here. So we see here again, we can see here a normal vessel in there, and also distal, we see that there is organized thrombus occluding the lumen. And we have the Ivis catheter in here, this all organized thrombus, and the Ivis catheter just fits in or is occluding the last part of the lumen. This is already distal.
Yeah. So Jurgen, again, so this is organized thrombus.
Yes.
So this is not acute. Acute would be white. Subacute would be more like a sort of a honeycomb meshy image, while this is clear and black. And you can even see it on the longitudinal view. If you go through it, you can see it really distal in the vessel. You see these black spots here and there, which correspond to the organized thrombus.
In there, yeah. And you see that the organized thrombus is always attached to the wall, because the organization comes from the wall. It goes from outside to inside. So if we go more proximal, and here you can appreciate this bright lumen there. And there is lumen, there is flow in there, but because of the vessel is partly blocked, you have slow flow. And that looks like a little bit like platelet aggregation. But in this case, it's not platelet aggregation, but just blood that cannot move fast enough. Faster moving blood is darker. See darker speckles.
Can you put the play button again, Jurgen? So
yes, I will do. I will do. There we go.
Appreciate the difference.
Yeah. Here you go. Now I'll let it play. You see the difference between the slower flow, the sluggish flow, but normally you have a darker lumen with blood speckling, but definitely darker. And the problem is that we have 2 regions with thrombosis. And here we see in the stent, we reach the stent now. You can see the stent dots in there. There is organized thrombus in the stent. And also more proximal, we pass a side branch at 5 o'clock. Here we have also organized thrombus in the stent. Also some subacute material. And again, here the Ivis catheter is occluding the lumen because it's full with material. And again, here, sluggish flow around that. We appreciate the lumen. On the side, you can now appreciate the black spots on the side. Here's on 1 o'clock, a huge mass of thrombus. So we call this late stent thrombosis because this thrombus is there already for some time, partly occluding the vessel, and then at a certain moment it was completely occluding.
Yeah. But what is key here indeed, as Jurgen,
Yeah.
this is late stent thrombosis mainly because of the fact that it's within a year after
Yeah.
stent implantation. But the
Yeah.
key thing is that within the stent, you see only thrombus. You
Yeah,
see
that's
no
correct.
neoatherosclerosis,
Correct.
meaning there's no excessive neointimal
No.
tissue, no calcium, and no neovascularization. So this is absolutely just thrombus.
And this thrombus was already there. It is developing already for some time there.
Yep.
Yeah.
Yep.
And then the last part was then came.
Yeah. So if we go back to the slides, in this
Yeah.
case, you can already appreciate that putting a new stent here is probably not the way to go, because this old stent is nicely patent and nicely open. We don't see clear malposition here and there, but we do see a lot of thrombus. So that's why the operator in this case decided to proceed with thrombectomy. And then with that, restored the flow in this LAD. Then the operator proceeded by doing another pullback, which we will show you now, which will show you the effect of the thrombectomy. And this is something that many of you probably will have never seen, to see what the thrombectomy actually does to the thrombus within the vessel, if it's so apparent as in this case. So if we go back to the Ivis.
Yeah. There it is. So in the meantime, we loaded the other pullback. So we start in the distal LAD again, and it's a normal vessel here. We've seen the normal 3-layered appearance. So one effect of the thrombectomy is that here we have some spasm.
Yeah.
The vessel is spastic in there. You can appreciate that here it's normal and here it's spastic. You can recognize a spasm that now your intima is thicker because the mass of intima has now less room, and so it's getting thicker. Probably with some nitrates, it will resolve. So here we're in the stent, and now I let it run, and you still see that there will be some thrombus and organized thrombus rest visible. Goes a bit slow, but here we have the side branch. But you appreciate that a lot of the material is gone.
Yeah.
But still there is some material left
remaining.
Remaining.
Yeah. So what is interesting here, that you see distally the thrombus is gone.
Yes.
In the distal part of the stent, the thrombus is gone, except for proximal in the stent. There is, you see here on the blackish spots within the artery, there is still thrombus remaining.
Yeah.
And it's a little bit difficult to appreciate because of the image that runs a bit slow, but I think, Jurgen, that we can conclude that that is the case in this.
Yeah, what I often see is that the more organized the thrombus is, the more difficult it is to get it away, get it out. Yeah, so.
But that is obviously also one of the key reasons we're running this trial, to see if some types of thrombus can be easily or more easily aspirated as compared to other types, which could help us to further fine-tune how we could use thrombectomy or ballooning or any type of placothrombus modification prior to stenting in these cases to optimize post-procedural flow. So if we go back to the slides, we'll take you through the rest of the case. So this was the pullback we've just shown you. Because of the remaining thrombus in the proximal part that was resistant to the thrombectomy, the operator in this case decided to do some balloon dilatation with a 305 NC balloon, and then repeated the Ivis. Maybe we can have a final look at the third pullback, Jurgen.
Yeah.
So this is the pullback after the third maneuver.
It's, well, I will do by hand. So we see that merely distal from the stent, that the vessel is normal.
Yeah.
And what you also appreciate is now this darker aspect of the lumen.
Yeah.
So the sluggish flow is gone.
Yeah.
So there's now more flow. Probably you appreciate also that the spasm is gone.
Yeah.
And so if we move to the stent, then we see that the thrombus is, you see, still there is some organized thrombus visible at the wall, but now we have a larger lumen, it's more compressed. You'll never remove it completely, but now we have a good lumen in the stent, and you can appreciate it also by the darker aspect of the lumen, the speckling in the lumen, indicating better flow. And that you will appreciate also on the result on the angiogram.
All right.
Yeah.
So let's have a final look at the angiogram.
Yeah. The slides. Yeah.
So here you see the result post thrombectomy, post ballooning of the proximal part, and post some nitrates, which shows you here a nicely patent vessel with TME grade 3 flow. In our opinion, an interesting case, because this shows you that STEMI not necessarily means new stent. Specifically, if there is already a stent in place, it is crucial to assess if this previous stent is well expanded, and to assess whether or not there is new atherosclerosis that might mandate the implantation of more aggressive ballooning or new stents. In this case, that was clearly not the case, and this patient should survive with better types of probably platelet aggregation. We performed some P2Y12 CYP2C19 testing to check if this is perhaps a clopidogrel non-responder. But in this case, proceeded with ticagrelor. All right. So far the first case. If there are any questions, please don't hesitate to interrupt us, and we would be honored to take your questions. So case 2 is also a STEMI. So this is a 65-year-old male patient with hypercholesterolemia, pulmonary embolism 10 years ago, who presented actually with an out-of-hospital cardiac arrest. He had VFib, he was defibrillated twice, but then quickly recovered. So he actually arrived here fully conscious, but with a clear STEMI anterior. And also he underwent the Ivis guided PCI within the Spectrum trial. So also here we started with a diagnostic angiogram of the right coronary, which is diffusely diseased, but clearly no significant lesions that wanted treatment at this stage. And this was the left side. So just as in the previous cases, it included proximal LAD, no previous stents in this case. And also here we proceeded with a Ivis pullback.
So
we can go to the Ivis.
Yeah. So then we did the first pullback in there, and we started in the distal LAD. You see that the vessel is quite small. We have, in this case here, we started with some intimal thickening, and if we proceed more forward, then we see eccentric fibrofatty plaque. So this vessel is not normal, but is already diseased, and we see that there is disease everywhere. Some normal spots are present, like in this region, and what you also appreciate again in here, that we have, and if I put this in movement, then we again have this sluggish flow, this slow flow in there, indicating that somewhere more proximal, in this case, the Ivis catheter is occluding something. So if we go more proximal, then we go in here with at a spot with some fibrous tissue, and here we get calcification, and also we reach here the spot where we have the subacute, more subacute thrombus. I'll put it in motion.
So what you can see here is excessive positive remodeling.
Yeah.
You can see within 3 and 9 o'clock that this vessel is truly enlarged towards the outside of the vessel wall.
Yeah, so it's
with a lot of eccentric plaque
and
inhomogeneous appearance.
And then around here we have the thrombus occluding the vessel, and it's now occluded by the Ivis catheter. You can appreciate, because you close proximal, you see that there's sluggish flow. Proximal is sluggish flow, and here it's dark and it's the vessel is occluding there.
Yeah. So Jurgen, is this thrombus or calcium?
Now I
think
it's
a combination.
It's combination. I think that there's calcium. That we see some deep calcium. We may see some thrombus in there, and can be also a part of, but that's a bit difficult to see here. I would say that we appreciate more subacute thrombus in combination, indeed, with some calcified plaque in there.
Exactly.
Yeah.
So no organized thrombus in this case.
In this case, no.
Okay.
No. Subacute.
Subacute. So we hope you already start to appreciate that. So you see not these black spots that we just saw in the previous case of indicating organized thrombus. We don't see here. There is virtually no flow because the lumen is virtually occlusive because of the subacute thrombus at the site of the probably plaque rupture, which with Ivis sometimes a little bit difficult to recognize given the complexity of the underlying plaque.
You can appreciate that more proximal there is also thrombus. Huh?
Yeah.
That's you can appreciate it, the irregularity. You can irregularity of the material. What is also obvious for thrombus in there. There is some lumen you can appreciate around 8 o'clock, but on top of and at 6 o'clock we have some regions with thrombus, especially at the 12 o'clock. You see it filled there with material.
Yeah. Yep. Okay, so in this case, the operator also decided to proceed with thrombectomy. So if we go back to the slides, we proceeded here with thrombectomy, and then restored flow. And you can already appreciate here that the plaque we already recognized on the Ivis ranging from the proximal to mid LAD was clearly apparent also on the angiogram here. Given the sluggish flow, the operator proceeded with a small 2.5 15 balloon, and then repeated the Ivis to assess the remaining amount of plaque and to use the Ivis to help guide the stent sizing. So if we go back to the Ivis.
Then here we started. I show you a part with a normal vessel. And what you also appreciate immediately is that the lumen is darker. So that means that the flow improved after this thrombectomy and after the balloon dilatation. Now that is actually what we also want to emphasize in there. You saw we did an Ivis in the thrombus in there, and you saw that we didn't make any attempts of making measurements. You see, it's no use because you're going to do the thrombectomy, but you're also going to do a pre-dilatation, which may also cause what would be normal dissections, and you want to take this dissection, the length of dissection into account with your sizing for your stent. So it's no use to measure before you do a pre-dilatation.
That's a very important comment, Jurgen. So always think, like with any diagnostic modality you do within medicine in general, I think, if you do Ivis, think, why am I doing this? Do I want to recognize the type of plaque? Do I want to identify how much calcium there is, which will then determine my treatment strategy? Do I want to confirm the amount of thrombus? And only then you can make your procedure fast and easy with respect to the use of Ivis. So no point in doing Ivis and directly start measuring. Just do whatever is intended based on the initial pullback. So here the first pullback was just intended to quantify the amount of thrombus and to quantify the type of the plaque. Based on that, we did some lesion preparation with thrombectomy and the balloon. Then did a new pullback, and this will be the pullback that indeed, as Jurgen mentioned, will be used to guide stent implantation.
Now, then I think it's time, because what we saw here, there's better flow. Of course, there is still thrombus there because we didn't remove the thrombus there. We saw some cracks in the thrombus, but definitely I wanted to show this in here at 7 o'clock, and at 10 o'clock you see a crack that is also after the pre-dilatation in there. And now it's time to see where are our landing zones of the stent? Where do we want to have our stent? So then I suggest in this case, let's find a landing zone and hope that also the initial operator did the same. This we want definitely to cover.
Yeah.
This,
so what we do, so we go to the side of the plaque and then go, let's say 1 to 5 millimeter distal to the area of the plaque in a region where there's at least 180 degrees of visible EM, but preferentially the more the better. And in this case, I think, Jurgen, we can find an area which has virtually no plaque.
Exactly.
Although there is some spasm.
There is some spasm in there. But that means
Dr. Daemen and Jurgen, one note, is it possible to use an annotation feature or your cursor to point out?
Yeah, that is what we tried.
Okay.
That is what we tried, but that didn't work. I cannot get I can see my cursor on on the thing, but it doesn't transfer it. That's, I'm sorry for that.
That's okay. Just keep going. I'm sorry to interrupt.
Yeah. So what we do, I think that we, well, there was some spasm again in here, and I suggest that for the sizing, let's make this as our landing zone.
Yep, I agree.
Yeah. Then what I do is I always measure an area, because for free, you always get for free
the diameters.
The diameters.
So with the Kodama console, you can use a touch screen to do this. It's actually quite convenient.
So here we have, well, the area is 3.6. That's of course no 4, but 4 is not the saint, because it depends on the size of the vessel. This is quite distal. So a 3.6 with a normal distal vessel, that's normal. What is more interesting here for our sizing, 2.3. 2.07 is the diameter. So we can make automatically it made the bookmark, so we can always go back to that. And let's find our proximal landing zone where we want to have the stent. Well, you appreciate that we want to cover this. We cover a side branch. We want to cover this part here. We want to cover in there. So we find the lumen that you like that would be sufficient. And I would suggest, well, there I would go a little bit more proximal. I would go for this one.
Yeah. So you see already a lot of difference. You see a very long segment with a lot of tapering.
Yeah.
Recognizing that distally there might be some spasm.
Yeah. And I will measure again the lumen. By the way, I'm working now with a mouse because that goes a bit easier because my screen is a little bit small, but you can do that also with a touch screen. In the meantime, here we have 3.4 by 4.1. Mm-hmm. And now we have 2 bookmarks for the landing zone. And the next part is to measure the length to measure a length between, sorry, between the bookmarks.
So ACIST is developing a feature that will provide you with an automatic length measurement within two bookmarks. But at present, you can, sorry, relatively easy do that by just dragging the cursor from one bookmark to the other.
Yeah. So
to make it a bit smaller, Jurgen, then it's easier. Yep.
Yeah, there we go. So we go from one bookmark to the other. That's right here. And then we find a length of, and then I have to make it a bit bigger again. Yeah, a length of, it's written in the middle here in the green, 43.7 or 44 millimeter stent.
Yep.
Then we have a big caliber change between the proximal and distal landing zone, about 2.5.
Yep. So this is a STEMI case with a vessel that was still a little bit spastic. So if you go back to the angiogram, you can appreciate that the operator in this case, this opted for a two-stent strategy, I think, which at the end makes sense. We don't have, most stent brands don't have stents longer than 40 millimeters. So we opted here for two-stent strategy, a 3023 and a 4023 drug-eluting stent, with a acceptable result. However, still some signs of no reflow. So we proceeded with the Ivis. So again, obviously, you know, this is the risk of entrapping a lot of soft lipid-rich plaque and thrombus with in this case 46 millimeters of metal in length. The risk of distal embolization clearly increases, as was also the case in this patient. But what you can never distinguish is this distal embolization because of plaque protrusion that embolized distally, or is the sluggish flow or TIMI grade 1 flow, as in this case, due to the fact that there might be a distal edge dissection that might also impair the distal flow and clearly warrants a different approach in terms of further treatment optimization as compared to just no reflow because of plaque protrusion. And that's where also the Ivis can help. And that's also what we did in this case to assess the potential treatable mechanisms of the no reflow in this case. So if we go back to the Ivis.
Yeah, then we're starting in the distal LAD, which is normal. So if I cannot see any embolization in here, and then we're close to the stent. By the way, this part here, in the meantime, this is a sign of a little that the priming was not exactly sufficient.
You mean the flushing of the Ivis
catheter? See, that's why it's getting a bit darker. Then you get this ring, and I always say this is the ring of self-confidence, because you must be very self-confident to continue with this without reflushing. But anyway, and then we go first to the distal stent edge, and then we can check for edge sections. And this is how you do that. You let it move up and down, and then you check all around if you see disruptions in the plaque, a tear in the plaque, and like that. Now, in this case, even if I have my correct glasses and I look at this big screen there, I don't see any disruptions there. So there's no edge section at the distal edge.
Plus, what is important is that we could confirm here with the Ivis that we landed in a very healthy reference segment. So that is one of the two key things you need to adjudicate at the edges. One, is there a dissection that you might be willing to treat if it's longer than 3 millimeters, or is there a significant plaque burden? And we typically use the threshold of a plaque burden of 50% to consider additional stenting if possible. But in this case, there's clearly an optimal landing zone with virtually no plaque.
So then we move forward, and I do that by hand because the playing ground is a bit slow, but we see in here in this stent what that the calcium makes the stent a bit elliptic, and sometimes, and often if it's very strong, I call it under deployment due to calcium. And then I used to say in the past, and still now, you can push with your whole family against that. You will never get this round. But what we also see here is that we see thrombus protrusion in there, and that is not that strange. You did a good job by optimizing the stent with your post dilatation, and at a certain moment there is no room for the subacute thrombus there behind the stent, and so it will protrude in there. In the meantime, what I always see also, I look for apposition. So far, all the stent struts were well opposed against the lumen wall. Here we have, we overlap a side branch. So the side branch was jailed by the stent because all the stent struts were in front of that. That doesn't mean that it's bad.
But it also, Jurgen, is quite reassuring. So if you go back to the side branch, and that's how, if you use Ivis for bifurcation stenting, for instance, this is extremely helpful. If you do, at least if I do bifurcation stenting, I always do Ivis up front. If I do a pullback in this case, LAD, and you see an ostium of a, for instance, large diagonal like this, you can be really confident that if you pick a provisional approach, that this large diagonal will remain patent. So that means I rarely use two wires. I don't use wires to protect the side branch because I can be pretty confident that this large diagonal will remain open after provisional stenting in a pre-PCI setting, but this also, even if you confirm that in a post-PCI setting, that is quite reassuring. So if you see this, I'm always very confident, and I'm very reluctant to do additional rewiring or crushing of the struts, because if you would measure this, you would see that if you would properly need to crush that, you need to use a 3.5 or almost 4.0 balloon to completely oppose the sides with also disrupting the struts within the in the main vessel. Well, here the struts are nicely organized in front of the side branch. So
we continue to proximal, and probably you appreciate some more regions with thrombus protrusion, like at 6 o'clock. And also at 5 o'clock. That means that we had serious thrombus before, and then here we have our stent edge, and then you see that at the edge of the stent there is a lot of protrusion in there. And if I continue here, that there is some thrombus there which is not covered by the stent, but no real edge section in there, because it's
no real edge section. But what you can clearly appreciate is the difference between the distal edge and the proximal edge. So the distal edge was beautiful, free of disease, no dissections, but here in the proximal edge there is still remaining soft inhomogeneous material within the vessel wall. You cannot clearly see the EM, but there's clearly a plaque burden that is larger than 50%.
And a dissection in here,
plus here at 5 o'clock,
6 o'clock.
Yep.
And you can see it because there is the speckling behind that stuff in there.
So if you go a bit more proximal, Jurgen, you can hopefully appreciate a more healthy part of the vessel, which is here.
That's here.
So that's how also the Ivis can help you to optimize your treatment. In this case, decide on the additional stent length needed to cover this region.
Let's have a look.
So here is the circumflex. Here is the proximal LAD.
Just a moment. There's the circumflex that's coming at 11 o'clock. You can appreciate that.
So that's also the beauty of the Ivis. If you want to use it for stent sizing, always pick large side branches as your reference. I mean, Ivis obviously doesn't have the easy to use co-registration features like OCT, but in at least my experience, if you learn to identify the key landmarks on Ivis and merge them with the angio, which is actually very simple because you see the ostium of the circ on the angio, and also on the Ivis you can clearly appreciate where is the ostium of these large side branches. And adjudicate on the Ivis how far in the stent needs to be, or whether or not you need to cover a bifurcation.
And that's why we always make no exceptions, motorized pullbacks.
Absolutely.
That you always know. I start distal and
Yep.
I end proximal. So I just want to ask everyone who is still vacuum cleaning in the vessel, that means with your catheter go up and down and hope that you see something. Quit with that, because then what Joost just mentioned, that you can you have your reference where your references are worthless, of no use
Absolutely.
anymore. And if you do that, then you start to get a sort of standardization, and Ivis gets more easier even to also to perform that, because everyone will do the same. So keep your vacuum cleaning for at home to help your spouse, but not in the vessel. So
all right, let's proceed with some sizing.
Okay, there we go. We do again.
So you're now completely at the ostium of the LED. You can nicely see that in the longitudinal view.
Yeah.
So we know we could even put the stent a bit more distally.
So we're talking about now 3.8, which is for 4.5. Yes. And again, the machine is so friendly to create a bookmark for us that we can appreciate. And now we want to make sure that we overlap the former stent. So I suggest that we would go just in here. Here we see the stent struts, and just for the sizing.
Yeah. So it's always a matter of being pragmatic. In this case, the Ivis allows you to easily assess the size, but you also know that, in this case, the proximal segment is already 4.5. So that will.
But it's for the length. Well, I measure lengths of 15 millimeters. You can appreciate that in the green. Is it green? Yes, it's green in the green line there. 15 millimeters. That's you overlap the stent that you just implanted previously, and then we go to the landing zone just at the ostium of the LED.
Yep.
What did that take?
So in this case, they indeed took a 40, actually 13 stent. So I think that fits a little bit with what I mentioned in the proximal LED of 2 millimeters of leeway to make the stent a bit shorter. So if you go back to the slides, we can see that. Oh, my apologies for that. We can see that the operator here decided to put a 4/13 stent in the proximal LED, but then still suffered from a significant no reflow despite some nitrates and I think even some 2B3 inhibitor in this case. We did a final pullback actually to assess the final result.
Yes.
So you might wonder, is all of this really needed? All these pullbacks? Well, of course you could argue, but we have to admit that in our practice, with this system, with a very easy setup and a pullback speed of 2.5, and the catheter with a very good crossability, doing an Ivis run with 2.5 millimeters per second is less than 1 minute of work. So we believe that this is worth the effort. Plus, it also in many cases could save you the additional contrast you use for each additional senior run you make with contrast.
Well, let's have a look, I think. Well, by the way, can we go to the Ivis? So this is the final Ivis, and as Joost mentioned, well, we did a lot of pullbacks because we check everything, did it work like that, and also your final Ivis is important. I can tell you in our center, and that's always Murphy's Law, if the patient comes back and then you with a problem there, and then it will happen sometimes that, or more than once, that, well, let's see the Ivis. There was an Ivis done before, and then they forgot to make the final Ivis after the last thing, and then exactly there was the problem. So we couldn't see what went wrong. Well, in the meantime, we saw that the stents are well opposed. There's still tissue protrusion, you can, or thrombus protrusion in there at 5 o'clock. That we didn't remove. So we have now the proximal stent. It's well opposed, especially if you have a vessel size of 4.5, then it's important that you do a good post dilatation. The edges are always notorious for malposition, but here you also see that the ostium of the LED is covered and the stent doesn't overlap the bifurcation with the circumflex.
Excellent. Yep.
See, that's
Yep.
so I think this is a good result.
I agree. At least anatomically in this case,
Yeah.
very good result. But if we go back to the slides, you can see that despite the efforts in restoring the anatomical situations as good as possible, this patient still ended with no reflow, suboptimal hemodynamics, and balloon pump was left in place. Patient was transferred back to referring hospital 2 days later, recovering from his MI with a significant CKMB and troponin rise during the MI. Final case of today, Jurgen, a 86-year-old female.
Just for a moment.
Traditional risk factors: hypertension, diabetes type 2, AFib, ITP, and splenectomy in the past. Who presented now, or actually, who presented now with a STEMI infraposterior, for which she underwent a Ivis guided PCI of the right. So in this case, we started with a angiogram of the left system, showing you diffusely diseased left system, without any apparent significant disease, but clear lesion in the proximal right coronary artery. So also here, we proceeded with Ivis. In order, again, to appreciate the type of the underlying plaque, again, a third case that is completely different than the first two. In this case, there is flow, so you expect potentially less thrombus. And you also might expect different plaque phenotype as compared to the previous cases. But let's take the Ivis to demonstrate you what this ACS might have caused.
Yeah. So here we started distal in the right coronary artery.
So Jurgen, sorry to interrupt.
Yeah.
One practical recommendation: if you use Ivis, never start the pullback in the middle of the plaque.
No.
This will prevent you from doing any type of measurement to assess any potential distal reference segment, to assess whether something is spasm or just small caliber. Always start distal in the vessel. And with a pullback speed of 2.5 millimeters, this takes you 4 seconds to assess a full centimeter. So time here is not the issue.
No.
Take the time and take the opportunity to really use the 10 to 12 centimeters of the pullback length that you have with these systems.
Exactly, yeah. And you see here that we have a large lumen in here.
Very large.
Of course, there is some plaque because the vessel is not healthy, it's actually diffusely diseased. So we go more proximal, and then we see that the plaque will increase. Here we have, I would say concentric fibrofatty plaque intimal thickening. It's quite regularly. So we go more proximal, and then here we get in the region of problems. And you see here we have a concentric plaque fibrofatty at 6 o'clock, and we see calcification at proximal.
Yep.
Yes.
So superficial, 12 o'clock.
Superficial
You
calcium.
see the bright white spot with the black shadow
Yeah.
behind that is typical for calcium.
You see also here more than approximately 90 degrees of superficial calcium in there, and concentric fibrofatty plaque in there. Normally my colleague and I will score this as concentric mixed plaque. That means that there is calcium and fibrofatty, so that there is of both, all of both. So more proximal, we're going to find the problem. Yes, and the problem, we will appreciate that it gets in here at 7 o'clock. Here we have from 7 till 12 o'clock. 12 o'clock we see the calcium, and between 12 o'clock and 6 o'clock, and I will switch this movement on, we see some hazy material, and it's moving differently than the speckling in the lumen. So we have here subacute thrombus already here at 9 o'clock from 6 to 9. And what we also see that if you look at the calcium is coming inside. It's not following the vessel wall, but come inside. And that is typical what we call a calcified nodule, a sort of pimple with calcium in there. By the way, the terminology made different because calcified nodule, it's also called with, I think with OCT convex calcium, but actually we talk about exactly the same phenomenon.
That's correct.
So calcified nodule, and if you see in an article convex calcium, it's exactly the same. So, and then if we go more proximal, then you see at 8 o'clock, you see this mass, and I think everyone will recognize it by now that there is some subacute thrombus there. They see the lumen, and the lumen, you can see the speckling in there, and the subacute thrombus is against the wall in here.
Between 6 and 9
6
o'clock.
and 9 o'clock.
Yep.
Here you can see
here the cauliflower of thrombus.
I will
until the
I will
center of
brighten
the
a little
vessel.
bit the picture.
Yeah,
Now
that's
you can
better.
appreciate it. Yes. So I don't see any questions yet. So I think everyone gets.
I think Jurgen, you are very clear.
Yeah, but I think that everyone will be the expert on thrombus now
Hmm.
after this. I think. See, also here at 8 o'clock, 6 o'clock, you see this thrombus in this vessel. Here it's getting even more.
Yeah.
See a huge
But this
mass.
is a beautiful example.
Yeah. See,
Even
and
perhaps starting to become a bit organized.
I will see if I can rotate a bit the cutting lines so we can appreciate it a bit more on the longitudinal view. You can see it here on top. There's a thrombus and it continues all the way in here. And then more proximal, there we see again the calcium, it's in there. And I suspect that around this spot here at 5 o'clock, there might be an older plaque rupture. And also at 11 o'clock might be a plaque rupture.
Yeah. So in this case, it's quite complex to identify the exact site where you would expect the TICVA with the erosion or the plaque rupture because of all the calcium. So this is a vessel that clearly is diseased already for quite some time. Typically, most plaque ruptures do not result in a myocardial infarction, but just heal. And if they heal, you get calcium, and that's exactly what you see here. So you see complex, a mixed type of a mixed phenotype of lipidic and fibrotic as well as calcific plaque. But we also know that 30–40% of the thrombi in patients with STEMI arise from calcific plaques or even nodular calcifications that might disrupt the flow and are at some way thrombogenic. So the operator here actually proceeded. So the good thing about the calcium is that there is no concentric calcium, which would be a sign of very severe calcification, and there is neither signs of 270 degrees or more of calcium. Always you see virtually everywhere disruptions in the calcifications. So that means that the likelihood that a balloon or a stent would expand properly is very large, because if you have one shelf of calcium that is rigid and concentric, that has a much higher resistance as compared to different separate shells of calcium within the vessel wall with soft areas in between that probably will not hamper the expansion of balloons or stents. So if we proceed with sizing, actually the operator in this case, namely, decided to directly proceed with stenting.
That means that he would ask now for a measurement here. And that means that we have to find a bit the nice, the landing zone. So this we want definitely to cover. So I start now proximal to find a proximal landing zone. And I think this would be a nice one. You see, there is plaque in there, there's even calcium in there, but I think if you look at the lumen there, and if we would measure the plaque burden, I think it will stay within the 50,
absolutely,
the 50%. So I will make a measurement in here. Again, guys, if you try this at home, you don't need a mouse. You can follow with your finger. It will follow your finger while drawing. That's a nice thing in there. So again, 4.5 millimeter in diameter by 4.06. So that will be a large one. Now we go distal. And I suggest that we land up in here. We covered the we go more distal. We want to cover this spot here, and I think this is a very nice landing zone. I will quickly do this because I think that we're running out of time. Well, time is flying when we have fun, isn't it? And then we have here 4.09. Then I owe you still a length measurement. So we go like this, and then if we see the lengths, then we see 33.5 millimeter between the two landing zones. 4.0, 4.5, so that will be, I think, a larger stand.
So if you go back to the slides, the operator in this case indeed stented the whole thing with 2 overlapping drug-eluting stents, post-dilated with a 5-hole balloon. Even did the proximal part with a 429, dilated the whole thing with a 5.015 NC balloon, and ended with a long standard segment, but a good angiographic result, TME grade 3 flow. And the final Ivis actually only could confirm that. So if we can show this final pullback of today, then I think we can conclude here. So again, distal edge.
Distal edge, we check the distal edge here. The stents, sometimes it's a bit difficult to determine your stent stress against calcium, but here they are. We go up and down, we look for disruptions. I don't see them clearly, it's more the calcium, so no visible edge section. So we move in here, and in the meantime, I know everyone is looking for thrombus protrusion. Actually, in the haste, we didn't see, a bit at 11 o'clock, at 12 o'clock, we saw a little bit. So we go more proximal, and then we see that we're outside the stent in here. We have the struts coming in here. Now it's without any edge section. So I think also here, there's a good
excellent result, good landing zone, whole thing covered, proper expansion, proper apposition, and good landing zone. So those are the key criteria for optimal stenting. So in this case, clearly met. So if we go back to the slides, we conclude with this. So we hope you enjoyed this 4th edition of our Ivis course we do together with ACIST. We hope that in this course you learned something about the different phenotypes of plaque and calcium and thrombus you might encounter in patients with ACS. How Ivis can help you to tailor down your treatment approach to assess everything ranging from thrombus to plaque characterization to calcium, to sizing towards final pullbacks that will help you to adjudicate the final result. And with that, we would like to thank you again for watching. Wish you a nice evening, and we look forward to seeing you next time to be with us in a next edition of the ACIST Ivis courses. Thank you.